understanding what's happening to you when you have breast cancer is absolutely critical. And so it's our responsibility as health professionals, not just to tell people stuff, but to actually have a conversation and a discussion that shows that the patient actually understands what we're telling them. So informed consent means not just that you've told someone something, but that they've actually understood what it meant and what the impact of that might be for them in a personal way, and they've had a chance to ask questions. So if we're actually not using language well, then all of our informed consent is not valid, and patients have difficulty adjusting to what's needed for treatment, but also then fears and concerns that don't actually get addressed. Research shows us that after receiving bad news, anxiety, distress, anger sometimes as well, is likely to wash over the patient. And for at least the next few minutes, they're probably not going to be processing terribly well anything you say to them. So that's a good time for doctors to shut up and actually use ways of showing empathy rather than trying to give information. Patients say after the event, it was just a blur. I have, no idea what they said to me next. And so that's worth us remembering, because we're responsible for what happens in that conversation. One of the commonest misconceptions in language is actually use of the word positive. So in ordinary conversation, if I said to you that it's a positive result, you'd think, you beauty, that's great. We use the word positive, though, in a breast cancer sense to mean a positive lymph node is one that's got cancer in it. A positive margin is a situation where the surgeon hasn't been able to get all the cancer out. Hormone positive cancer might be a good thing to some people and a terrible thing to others. And HER2 positive breast cancer used to be a terrible thing. It isn't anymore because we know how to treat that. So that simple word positive is very confusing for patients. Another good example that's used by health professionals is the idea that if a treatment isn't working for a patient, it's common to hear people say in conferences, the patient failed first-line treatment. Well, the patient didn't fail, the treatment failed. It didn't produce the result that we wanted for that individual person. And it's almost as if you're trying to put the blame back on the patient for the fact that the treatment didn't work. So clearly that's not something that should be used in conversation with patients. So just because you're focused on learning the jargon, don't forget that ordinary words are going to be what you're using in conversation with patients. Clinical trials have eligibility criteria. Eligible is a word we use about bachelors. It's something that's great about someone. So if you say to a patient, I'm sorry you're not eligible, straight away they're thinking, oh, failed again. First of all, I've got cancer and now I'm not eligible for a trial. Not a great place to be. So what we should say instead is, this trial is not suitable for you, and let's look again in the future because other opportunities may arise. So thinking about the sorts of language we use may be the difference between someone being interested and willing to be involved in a clinical trial that could save their life and running away because it all sounds too scary. One of the things I've learned is that you should always check that people have understood what you say. And that might be because they're in a moment of strong emotion. It might be because their level of health literacy is not very high. Even simple words that describe parts of the body, the liver, the axilla, things that people may not understand, especially if English is not their first language. We do a lot of communication skills teaching with oncology professionals. They were actually the pioneers in this area in Australia. And so all of our oncology and surgical trainees come through a rigorous communication skills training program. And that's run through the Pan McLean Centre at the University of Sydney. And there are other providers around the country. What we do is we work with actors, they portray the role of the patient, and they give feedback to the person who's participating. I didn't get that. That didn't feel like empathy. So it's not something that stops when you leave medical school. It's something that continues throughout your life. In terms of resources to help sensitise people to how it feels to be a patient, reading memoirs of people who've been through a cancer experience can be very useful. There's a great book by Ben Bravery called The Patient Doctor, and his experience of having colorectal cancer inspired him to become a medical student and now a psychiatry trainee. And just seeing it from the other side is something that can help to open your eyes to what it's like to be a patient and how many simple things are easy to misunderstand.